Good morning, good afternoon to you all. It's a pleasure for me to be able to introduce the virtual International Fabry Conference. It is true that in the situation of the COVID pandemic and everything that has happened for us, it is a little bit complex, and we are now forced to do things that keep us connected. It's a pity that we cannot be meeting face to face, but it's also very good to be able to continue meeting and to keep on in touch with our patients. I would like to express my gratitude to Dr. Guillem Pintos, who has collaborated with me in putting together this really relevant agenda. Let me also express my gratitude to all the speakers who are going to participate in this conference, world ranking figures. And let me thank the Fabry International Network. We are members of this organization and we participate very often in their events. And I would also finish by thanking the participants, the families, the patients, the pharma companies for their participation in this kind of events, and to all the speakers. So I think that in the lysosomal diseases, Fabry is a very, very relevant pillar, and we will continue giving support to all initiatives to fight this disease. I wish you a wonderful and very fruitful conference, and I hope that we have lots of questions, a lot of discussion, and draw many conclusions to learn more about Fabry disease. Thank you very much.
Muy buenas tardes.
Thank you very much, and good afternoon to you all. Thank you, Jordi, for this introduction. Today, my role is to introduce the first part of our conference, and as you will see, we have organized a meeting, as the title says, with many different specialists, all together for Fabry. This is our objective, to provide this wide view of Fabry disease and to discuss all the main aspects. Of course, not all of them, but most of the most relevant aspects to cover them.
Para iniciar, digamos, la
to start this afternoon's session, we have here Dr. Vicente Climent. Dr. Climent will tell us about Fabry cardiomyopathies. Mr. Climent is a specialist physician. He's a specialist in cardiology at the Alicante University Hospital, and he is in charge of the familiar cardiomyopathies and cardiac failure at that hospital. He's also a member of the Biomedical Research Center at Alicante. He's a principal researcher and coordinator of a research group on cardiovascular diseases in Isarian. So, Dr. Vicente Climent has collaborated with the MPS Association, MPS Lysosomal Association in many opportunities. And this is yet another example of his participation. He is very generously helping us to update all of the most relevant information about Fabry disease. Without further ado, I would like to give the floor to Dr. Climent by thanking him for his collaboration. Thank you.
Good afternoon. Thank you very much for your kind introduction. And thank you to the organizing committee for having invited me to be here and share these moments with you. I'm going to explain to you the importance of the heart in this disease, that is Fabry cardiomyopathy. In this event, everyone knows what's Fabry disease. I just want to remind you that it is a disease produced by a mutation, an alteration in the GLA gene, which is going to produce enzyme alpha-galactosidase. It will have a deficit in its production, and so it won't be able to degrade certain substances such as globotriaosylceramide or globotriaosylsphingosine. And this is going to lead to tissue damage in the tissue and in different organs, leading to signs and symptoms in our patients. Since this enzyme is found almost in all the cells in the body, the storage of this substance is going to happen almost in all organs in the body: the eye, the bowels, the central nerve system or peripheral nerve system, the kidney, the brain, and of course also at the heart. The damage in these organs will lead to signs and symptoms which are specific of each organ. But why do we talk in this meeting about the heart within Fabry disease? There's several reasons. First of all, because it's a very common alteration in Fabry disease. Between 50 and 60% of patients with Fabry disease will have heart involvement in some of its forms. We know that almost half of the males will develop ventricular hypertrophy, and almost 40% of females will also have ventricular hypertrophy. In the case of males, as we can see here, cardiac involvement is a bit higher, 61%, and it's earlier. We see it around 30 years of age. And in the case of females, cardiac involvement is a bit lower. It's of about 50%, and it appears later, around 40 years of age. On the other hand, this is not only important because it's very prevalent, because heart damage is common in this type of disease, but it's the main prognostic factor for disease course. We know that in patients who are not receiving treatment, specific treatment for Fabry disease, cardiovascular disease in any of its forms accounts for about 50% of mortality causes in these patients. This is important because in the general population worldwide, cardiovascular disease or ischemic heart disease account for 16% in deaths in the world. So, you know, the origin of mortality or complication account for 53% of the cases, which shows us how relevant, how important is cardiac involvement in this type of diseases. Why and how do we have cardiac involvement? As I said at the beginning, organic damage is caused by the storage of GB3, globotriaosylceramide. And since it cannot be degraded by the alpha-galactosidase enzyme, it is going to be stored in all the cells in the body. At the level of the heart, it will be stored in cardiomyocytes, which are the main cells in the heart. It's the muscle cell, and this will lead to ventricular hypertrophy. But we're going to see it also at the level of the valve. So we're going to have valvular damage. We're going to see storage at the conduction system, leading to arrhythmias, slow arrhythmias, and fast arrhythmias, such as tachycardia. And we're going to see storage also in vascular endothelial cells, in those arteries supplying the heart for it to work correctly. This is going to cause stenosis and damage in these arteries, leading to chest pain and angina, similar to myocardial infarction, as we'll see later. So in Fabry disease, concerning cardiac involvement, we have changes in the cardiac structure. We have changes in cardiac function. We're going to see signs and symptoms caused by this alteration of cardiac function. The main symptoms will be palpitations, chest pain, and especially shortness of breath and fatigue. Let's remind ourselves that there are two kinds or two ways Fabry's disease can express itself. We have the classical form. We see, involvement all over the organs, cardiac signs and symptoms are seen within the general damage in these patients. We have eye alterations, GI alterations, etc. But there's another variant, there's the cardiac variant, and here we see alterations mainly in the heart. The organ damage, it's the heart mainly. And so signs and symptoms are heart signs and symptoms. So it will be more difficult to get the right diagnosis because we will think that this is a different disease. If we talk about different damages that we see in the heart, the more characteristic one is hypertrophic cardiomyopathy. It's a thickening of the heart walls, and this affects both ventricles. This would be a normal heart with normal thickness, but here in Fabry disease, we see hypertrophy. We see this thickening of the walls, and this would be a cross-sectional heart with disease. Why do we see this hypertrophy? Not only because of GB3 storage, as we've mentioned, this is what triggers the whole process, but we know that GB3 store in the heart, it's 1 to 2% of the heart mass. So there's something else causing ventricular hypertrophy. I'm not going to give details about this slide. I just wanted to show you that the pathways created from GB3 storage are going to cause inflammation, apoptosis, leading in the end to hypertrophy and fibrosis. But this is a very complex process. Here we see anatomical specimens, and you can see the thickening of the heart walls in this type of patients. And this is what we see with diagnostic tests. This is how we see in the ultrasound, which is the main test we use to diagnose these patients. Here we see the hypertrophy of all the walls, right and left ventricles. Here we see something similar to what we saw with that specimen. We see that important thickening of the walls. It is also important to emphasize that cardiac damage increases with age. If we don't treat the patient, if the patient doesn't get specific treatment, the likelihood of developing heart damage increases. As we see here, with increasing age, the higher the prevalence, the higher the involvement. of the heart. And here we see that the higher the age, the higher the heart mass, the size of the heart. Another important thing in this disease, it's not only ventricular hypertrophy, but also the presence of heart scars. That scar that we see and that we call myocardial fibrosis, we can assess it with MRI. This is one of the other important tests we use, MRI. Well, the MRI shows us this fibrosis, these white areas that we can see in the MRI scans. And this shows that there are scars in the heart. Today, there's also different techniques, more specific techniques, and I'm going to mention this because they are becoming increasingly popular in conferences. And I'm talking about the T1 mapping, which allows us to have an earlier diagnosis of cardiac involvement in these patients. I've already talked about the main damage, which is ventricular hypertrophy, but as I said, there's other types of cardiac involvement. So, and we have, for instance, damage of the heart pacemaker, and this will lead to arrhythmias. There are two types of arrhythmias. We can have bradycardia and blocks, that is, the heart goes really slowly, or we can have tachycardia, tachyarrhythmias, some of them benign, but others may confer risk to the patient, and they could lead to sudden death, even though it's very uncommon in this type of disease. Although it exists, and we have to assess the risk. I'm not going to give you details. This is the typical ECG when there is a cardiac involvement, and it shows that with an ACG, we can collect data that may lead us to think about cardiac involvement. I've talked about ventricular hypertrophy, arrhythmias. Now I'm going to talk about valvular involvement. I've said that GB3 storage also happens in the valves of the heart, and this will cause damage and dysfunction of these valves. The typical involvement that we see is valvular thickening and valvular regurgitation. And then we see these problems, which are usually moderate and require repair or surgical treatment. And so we have to assess them. And finally, as I've said, we also have GB3 storage at the level of the coronary arteries, which are the ones that supply the heart so the heart can work. The storage of this substance in the coronary arteries will lead to vascular dysfunction and symptoms similar to myocardial infarction. In this case, it is not a myocardial infarction because there's no obstruction of the artery. There is a dysfunction of the small artery, of the capillary at the level of the endothelium. So the patient will have chest pain events, even though the coronary arteries are not obstructed. However, let's not forget that Fabry disease is associated with certain risk factors typical of cardiovascular disease, such as an increase in cholesterol, hypertension, renal failure caused by the disease, and all this could lead to atherosclerosis, arterial block, and finally, myocardial infarction. Even though myocardial infarction prevalence is very low in this disease, we cannot underestimate it. Having said that, I mean, this is what happens at the level of the heart. And I just wanted to emphasize or to mention the importance of the heart within the diagnostic process of this disease. When we have a suspicion of Fabry disease, we consider certain clinical manifestations and symptoms at systemic level, but we also collect data from cardiac imaging, such as ultrasound or MRI, which are the most important ones, as well as the ECG, which may tell us that there are certain signs and symptoms. And all this may help us diagnose Fabry disease. This has allowed us to establish some red flags, some warnings, which tell the specialist or the physician that when there is any of these symptoms, both extra cardiac or cardiac symptoms, the presence of any of these symptoms or red flags has to lead to a suspicion of Fabry disease. So this is an overview of cardiac disease in Fabry disease, but what do we do now with this concerning the heart? I'm not going to give you details because there are other presentations about treatment and different therapeutic options. I only want to remember that at cardiac level and at other organ level, we have to deal with it, approach the treatment from different perspectives. We may have to use supportive therapy if patient has chest pain or arrhythmias. We'll have to treat them, and we'll have to treat also heart failure. So that's supportive treatment. And then we have specific treatment for Fabry disease. There are two different types: enzyme replacement therapy and chaperones. The ERT can be IV and it corrects enzyme deficiency. And chaperone therapy, it's an oral therapy, and we will only be able to use it in patients with enzymatic residual activity. There are other therapies being developed and under investigation. Here we see an explanation of this. Concerning enzyme replacement therapy, it has shown that it improves heart manifestations, renal manifestations, neurological manifestation. It improves quality of life. Chaperones have a lower trajectory, but they have also shown improvement concerning cardiac manifestation, renal manifestation, neurological manifestations. I'm not going to insist on this because Dr. Pintos will talk to us about how important it is to start treatment early. I'll just remind you that when we have a GB3 storage at the level of the cells, and if we don't treat it, it's going to increase. When we start specific therapy, as we see here, we reduce this accumulation speed. So we're not always curing the disease, we just slow down its progression or delaying its progression. So the earlier we start therapy, the longer the patient will be free of disease. This is the same explanation. Here we see storage of substance in all the cells in the body. Then we see the onset of organ damage, and then the efficacy of treatment becomes lower. So we have to look for signs and symptoms that will allow us to diagnose the disease at earlier stages. And here, cardiac alterations have a very important role. If we know that certain symptoms and ECG changes, if we found them, we'll be able to diagnose the disease at earlier stages. I'm going to finish now with certain conclusions and ideas or some take-home messages. The first one is that cardiac involvement is very frequent in Fabry disease, and it's one of the main causes for morbidity and mortality if we don't treat it. We have to pay attention to symptoms which are very variable. Main symptoms are shortness of breath, arrhythmia, and chest pain. We have effective treatments to delay or reverse cardiac involvement, and the earlier we start the treatment, as we're going to see now, the better results we'll get. Thank you. And now I think that Dr. Pintos will talk to us about the importance of prompt or early treatment. Thank you.
Your mic is off, Mr. Pintos.
Debo encender el micrófono, doctor.
Muchas gracias, Vicente.
Thank you very much, Vicente. Thanks for your presentation. When I finish my part, we will have time for Q&A, where we can share questions and comments from the audience. I would like now to start with my own presentation. I am Dr. Guillem Pintos. I am part of the reference unit of hereditary diseases at Vall d'Hebron Hospital, and I'm also a member of the MPS, lysosomal MPS scientific committee. And today, in my paper, I will try to present some data to try and support the idea of how important early treatment for Fabry disease is.
Clic con el ratón encima del PowerPoint, por favor.
Entonces, para hacer un tratamiento
If we want to offer early, suitable treatment at the right time, we need to be very clear about the fact that there are certain early clinical signs or clinical markers, we could call them, which appear very early in the development of the disease. And here we can see some of the main ones, such as a cornea verticillata or a Fabry peripheral neuropathy, especially acroparesthesia, or skin lesions, which could be angiokeratomas, which can only be seen at the start in areas which are really hidden. Then GI manifestations, which are very common in young patients, and then other signs such as exercise and heat intolerance. Here, in these images, you can see the typical example of these angiokeratomas, which are these raised wine-colored stains, and here you see a description of how this classic Fabry phenotype is presented. This is the early onset version. You will see the peripheral neuropathy, hypohidrosis, no sweat, heat intolerance, exercise intolerance, especially at times of the year, such as what we're witnessing now with the impact of temperature, can be really relevant in these patients. GI manifestations are very common in the classical forms in young patients: angiokeratomes, tinnitus, or auditory changes, and a decreased heart rate variability, as well as sometimes very subtle changes in the ECG. Some of these early changes may already show that there are some lesions in some of the body organs. A cornea verticillata points at the existence of corneal deposits, and these deposits can be a relevant sign that could then lead us to think that these deposits could exist in other parts of the body. Then we have microalbuminuria. It's a slight renal change, and when a kidney has got this albumina, the kidney is not painful, so you really need to try to do a urine test. There are other ways of looking at these early signs, such as kidney biopsy, or to look at the heart volume changes, as Dr. Climent explained, especially the left ventricular hypertrophy, or to look at what the MRI can tell us, because MRIs can show deposits in the heart muscle, which then lead to changes in the MRI images, and these can show very, very early. That's what we see rather in T1 and not so much in T2. We finally have skin GB3 deposits if we have a small skin biopsy, which is not very invasive. We could test that. Here you have some images showing the GB3 deposits in different cell types, or even in vessels and nerves in skin areas. Here we see a cornea verticillata, and here we see the lipid deposits, the GB3 deposits in the kidney, especially in the kidney epithelial cells and podocytes, but also in the capillaries. Here, you can also see how we see a very early arrival of deposits in capillaries, in different vessels, and even in the perineural space. We see this buildup of GL3 in skin biopsies in very early stages in these Fabry patients. The Fabry classic phenotype starts very early, and we can use biomarkers to assess the existence of Fabry. The most classical biomarkers would be GB3 and lyso-GB3, which is more closely related to pathological and physiological changes. Then enzyme activities. Enzyme activity is changed, and that is a very important fact for males. When this enzyme production is very low, it's a sign that the disease will have a very early onset. Then we have the classical mutations, typically associated to more important and earlier manifestations of the disease. However, this is not the case with genetic variants of unknown significance. Here, we often need to look more closely and try to find the proof that these GB3 deposits do exist. And we can achieve that through a biopsy. This slide intends to show how, in the classical phenotype, there is a significant increase of this marker, the lyso-GB3 marker, especially in men, in males. Among females, it is harder to identify this, although high values can also be quite telling, especially for women with a classical phenotype. So, blood lyso-GB3 is high in all these manifestations of the classic phenotype. But whenever there is a residual activity, we can see lower buildups of lyso-GB3, and then it is more complicated to see where the cutoff point is and to see that this is an abnormal value. So the genetic alterations and the mutations that lead to the classic phenotype, which causes an early onset disease, lead to high lyso-GB3 in blood. However, GBUs, these variants of uncertain clinical significance, don't usually show a high lyso-GB3 rate. However, those mutations where the enzyme activity is residual, we can see some changes, but then we need to do much more sensitive tests in order to identify the lyso-GB3 buildup. We are currently working on a study, and the Vall-d'Hebron group with Dr. Carnicé, she is the first author, and we have published a whole set of biomarkers we are looking into. We are trying to understand if these biomarkers, which are associated to some clinical changes, can help us differentiate the different stages where we can identify inflammation. Inflammation would still be a reversible phase, or if they have become indicators of fibrosis and sclerosis, and here we cannot expect to have a full cure of the disease. We can slow it down, but maybe not cure it completely. Here we have a close-up of that image, and you can see this whole list of markers we are currently analyzing to try and see if inflammation-related markers or angiogenesis markers or ECM turnover markers, or maybe other markers that have to do with the inflammatory immune response, or markers we see in cardiac muscle cells, which could indicate that there is a change, there are changes in oxidative stress, or that there is an inflammatory response, or changes in collagen fibers. Well, our purpose, our hope is to see if all these laboratory data and markers can help us set apart the different phases of the disease to understand when treatment can still have a relevant impact and can revert the pathophysiological features of the disease. Here, we express the same idea in further detail, and we look at tissue involvement. Here we see the different markers related to the different cells which respond best to inflammatory phenomena and to fibrosis, both in the kidney, in the endothelium, or in the myocardium. We are heavily committed with these studies to try and find these biomarkers profiles, which could be more helpful for us. Dr. Climent already talked about this. He mentioned how useful MRIs are because they help us identify early cardiac changes. And here we see how MRI changes evolve over the years. This shows that there is a buildup of lipids and changes appear progressively as years go by. Let's talk about the kidney now. We clearly know that proteinuria, if it's high, will lead to a drop in glomerular filtration rates. There are some papers by Dr. Tondel, and she shows that in children between 7 and 18 years of age, there's always an important, well, there are very high deposits in the podocytes inclusions, even when microalbuminuria is low, it's relatively low. That's important too, because if time goes by and we start seeing hyaline lesions, they are irreversible, and that, well, prevents a full clearance of all renal inclusions. This is a paper by Dr. Germain. Patients at high risk of kidney disease because they have glomerulosclerosis and proteinuria, we see that despite of treatment, there is a relevant drop in their glomerular filtration rates. Here, we can see that as years go by, event-free survival rates become lower, and as glomerular filtration decreases, there's a higher risk of complications. And here, we have a look at biomarkers. The later we act, the harder it is to bring lyso-Gb3 values back to normal. And the reverse is also true. Doctors Licher and Derralynn Hughes were involved in this study, which shows that survival probabilities and event-free probability changes very substantially depending on whether treatment started earlier or later. We have done this study looking at patients who started treatment before 18 years of age or between 18 and 30 years of age, and those who started treatment over 30 years of age in cohorts which had symptoms during childhood. So these were classic phenotypes, but treatment had started at different stages in the patient's life, and we wanted to look at the impact of this timing. This is related to higher efficacy of treatment. Those who start late will suffer glomerular filtration rate drops and will suffer proteinuria. However, those who were treated before 18 years of age achieve a wonderful stabilization of the GFR, glomerular filtration rate. And regarding left ventricular hypertrophy, we can see that when the treatment starts early, patients have this normal ventricular mass, and this mass is maintained over time, up to 10 years later. However, patients who start treatment later already suffer hypertrophy, and they are not able to fully slow it down or revert it. So we recommend to start treating early. There are different recommendations to start as early as 10, 12 years of age if symptoms have already appeared. And also among teenagers at around 16 years of age with patients with a classic phenotype. For the non-classic phenotypes, we will have to look at the most relevant objective data, which would allow us to identify whether there are some organ lesions which could be invasive, such some of the tests could be invasive, such as kidney biopsies, but with the help of markers, both the classical ones and those which we are analyzing at the moment, can help us identify what the stage of the patient is before doing other more invasive tests. Here we see a sort of a schedule, a sort of a drawing which shows that we should start treating at the time when the disease can be reverted, because if we act too late when hypertrophy or proteinuria are already in place, the disease will probably might slow down at the start, but it will develop as well, and organ failure will eventually happen. And that's it. Thank you very much for your attention.
Well, now I'm going to have a look at the questions that we have received so that we can answer them, Dr. Climent and myself. There's a question here directed to Dr. Climent. It says, in order to differentiate Fabry cardiomyopathy from other cardiomyopathies in cardiac Fabry cases, are there any non-invasive specific test that allows to differentiate Fabry's etiology? What level of specificity does it have? This is a question from Ignacio Marin. It's a very interesting question for us. For us, it's always a challenge. When you find a ventricular hypertrophy, you know, it's very difficult to find out the cause. I understand that the question, refers to ventricular hypertrophy and that we don't have clear diagnosis. I mean, there's some tests such as echocardiography, there's some images and data in echocardiography, especially concerning the type of hypertrophy in the papillary muscles, which is very typical of Fabry disease. And then there are new echocardiographic diseases which are difficult to explain, but it's a kind of echography or sorry, ultrasound. And then we see that when values are very low, especially in the posterior inferior area of the region, that points to Fabry disease. And when we have genetic base or sarcomeric base, then this diminishes in a global way. The same happens with MRI. Like as we have said, both Dr. Pinto and myself, there are new techniques in MRI, such T1 mapping, and it's able to differentiate Fabry patients at early stages. In hypertrophic cardiomyopathy, T1 mapping times are normal or higher, and this is not the case when there's no Fabry disease. We also have data from electrocardiogram, which are very suggestive. For instance, a short PR interval associated with ventricular hypertrophy that could make us think of Fabry disease.
Muy bien. Tenemos también aquí.
We also have another question,
Sería.
which
Una va dirigida a mí porque.
I mean, one is addressed to me because it's about children. It says, if my 4-year-old son does not have symptoms and he gets a test every 6 months, he's fine so far, shall we give him therapy right now, or can we wait for a while? This is a question that Andrea has sent us. As I have said in my presentation, the start of treatment in children hasn't reached total consensus. A 4-year-old boy could not manifest any of the symptoms as you are saying, Andrea. But we have to base ourselves in genetic data. We have to look at how the disease has developed in the family, whether it's a male or female. That's important concerning the evolution speed of the disease. And at this stage, for instance, lyso-Gb3 and the enzyme deficiency could be almost undetectable, and that could tell us that the disease will have not detectable or not clinically detectable disease, but with some anomalies at organ level. In these cases, I would recommend to do these follow-up controls, as you are mentioning, regular controls in order to assess microalbuminuria, for instance, and some echocardiographies, even though at that age there's no alterations. But we also have to bear in mind that many children can start treatment early because of GI important manifestations, which prevent them to have a good nutrition and good development, and also due to peripheral neuropathy. There are some children who have exercise intolerance, who have heat intolerance, and so this makes them different from their peers, and that may have an impact on their mental health. We have to assess all this before starting treatment, and we have to bear in mind that if we're going to give enzyme therapy, based on the label around, we can start treatment at 7 years of age. But some children may have neurological symptoms, severe neurological symptoms, such as peripheral neuropathy. And in those cases, we could use compassionate treatment earlier. We have to assess case by case. We know that some children have required treatment very early due to severe manifestations of the disease. Vicente, there's a question for both of us here. It says, with lucerastat or Smart for Fabry pills, Smart for Fabry is an enzyme formulation with liposomes. So this treatment has a longer half-life, but lucerastat is being studied in ongoing clinical trials. And the question is that if lucerastat is being used, also enzyme replacement therapy should be used, or if the pills can be given by themselves. For instance, migalastat, that's a chaperone. Vicente, you have a long experience with this therapy. And I would change the question a bit, and I would say, enzyme replacement therapy or alternative treatments such as chaperones or substrate reduction therapy, can they be used by themselves, or should they be used in combination? What do you think, Vicente? With chaperones, we need more experience with we have more experience, sorry. With the rest of treatments, we don't have experience. Chaperones, we use them by themselves today. The patient can choose that, or enzyme replacement therapy, or oral therapy with migalastat. What's going to happen in the future? Maybe in the future, we're going to use combination therapies. But this is my personal opinion. I don't know what's going to happen. I think we're going to use combination therapies because probably the efficacy of each therapy by themselves does not achieve 100%. Does not cure the disease. And if we attack GB3 storage from different points and different pathways, we'll probably achieve higher therapeutic efficacy. But this hasn't been approved yet. There's some ongoing trials combining different therapies, I think. But it's still under research phase. Yes, I think that this is an area for future research. Now with COVID-19, different types of vaccines are being studied to see whether they can be combined. And with Fabry disease, now we have treatments which target different biochemical situations, such as substrate reduction. And I think that we could combine that very well with enzyme replacement. But of course, we have to show this in controlled clinical trials. But of course, I think that in classic Fabry disease, when it is difficult to have an adequate response, I think that we should, we could use maybe combination treatment in certain patients. I completely agree. Well, here I don't see any more questions in our chat. So since we're on time, I'm going to take advantage to introduce the next speakers. The next speaker is Professor Dominique Germain, and then we'll have Professor Derralynn Hughes. First, and following today's agenda, I'm going to introduce Professor Germain. Is Professor Germain with us?
Buenas tardes.
Good afternoon.
I will now change to English for the presentation of these two next presentations. And in the beginning, Professor Dominique Germain, he completed the doctorate in human genetics at the University of Paris 7. He obtained the habilitation in 2005 from the University of Paris 5. In 2006, he was appointed director of the French Referral Center for Fabry disease by the French Ministry of Health, a position which he has kept ever since. In 2016, Professor Germain was appointed director of the European Referral Center for Rare Disorders, METAP-IRN, for rare metabolic diseases at the Hôpitaux Universitaires Paris-Île-de-France-Ouest. Je pense qu'il y a beaucoup plus des autres choses, choses à dire de la évolution academic, the academic evolution of Dominique Germain. But I think this is very important to know that Dominique has been collaborating with the patient association for many years now, and he is always present in this type of events, and we are really very grateful because we know that he is really busy. So today the title of his presentation is the Fabry disease in the female patients and X chromosome inactivation in female heterozygotes for Fabry disease, and if we are ready for clinical use. So Professor Germain, please, you can go ahead.
Thank you very much, Guillem. Can you hear me?
Yes.
Entonces voy a empezar con algunas palabras.
Okay, then I'm going to start with some words in Spanish. First of all, I'd like to thank Jordi Cruz, my friend, and Dr. Pintos, Guillem Pintos, for this kind invitation to talk today here. It is a great pleasure for me to be here with you today. My Spanish is not very good, so I'm sorry I won't be able to give my presentation in Spanish. because otherwise we'll be here until tomorrow. So now I'm going to change into English. But at the end of my presentation, I'll try to answer the questions in Spanish, if there are any questions.
Now, and as Guillem told you, he asked me to tell you more about the Fabry female patient and the potential use of the X chromosome inactivation, which is the major research work in my laboratory. So to start with this very first slide, but I'm sure you're all very familiar to this, you know that Fabry disease is an X-linked genetic disease, so we will come back on this point. That is due to, we used to say a mutation, nowadays it's better to say a pathogenic variant in the gene GLA. So we have a small typo, you know, in the gene, a small difference, a small variation, which is in turn responsible for absent or very low alpha-galactosidase activity and the storage of GB3. This will be responsible for, in classic Fabry disease, a very multi-systemic genetic disorder with basically involvement of many different organs in the body. But of course, we used to stress the very important involvement of the heart. So we have hypertrophic cardiomyopathy in Fabry patients, both male and females, which can in turn be responsible for rhythm disturbance, so arrhythmia. You are also all aware of the risk of cerebrovascular involvement, in other words, strokes. I had an experience today with one of my female patients. We had to intervene in emergency. And of course, the kidney is also a major target organ of the disease. So some patients, mostly males, but occasionally some female, and I will tell you why, can progress to end-stage renal disease. For the purpose of my talk tonight, I would like to remind you that we are aware of several severity scores in that disease. So now there are some new scores, but at the time I started this study, the two main scores were the MSSI, which has been created in Germany by the group of Michael Beck in Mayence, and the DS3 score. So both of them are supposed to capture how severe is the disease. So the higher the number and the more severe the disease. So as I mentioned before, the gene responsible for Fabry disease is located on the X chromosome. It could have been located, you know, on chromosome 1 or 7 or 19, whatever. But in that case, it's on the X chromosome, and it will explain you why we can document some differences between male and female patients. Why is that? We are aware, we geneticists, of three major inheritance patterns for genetic disease. The first one is named autosomal dominant. We will not touch on it tonight. The second one is autosomal recessive. And the last one is X-linked. So we were used as a professor of medical genetics to distinguish between X-linked recessive and X-linked dominant. But on this slide, I put for you the that is already something like almost 20 years ago, where this colleague recommended to stop using recessive or dominant. However, this is something difficult because when I teach to my students at the university, I feel quite concerned. So I will ask you to follow me in the next slide and try to teach you and let you know what we call recessive, dominant, and why maybe indeed for Fabry disease, we should avoid to use those adjectives. So let's start with X-linked recessive inheritance. We are aware of a number of genetic diseases, of X-linked genetic disease, which in my opinion are truly X-linked recessive. Look at this first example. This is a pedigree of some royal families in Europe. By the way, for the Spanish, Juan Carlos. But the point is, we will start with the Queen Victoria of England. She was a carrier, so a heterozygous female, okay, carrier for hemophilia, okay? And in X-linked recessive disease, the female have absolutely no symptoms. So Queen Victoria lived very long, you know, I think up to 90 years. So was true for her daughter Alice, then her granddaughter here, Alix, who married the Tsar of Russia. And only when a little boy, you know, appeared, was the diagnosis of hemophilia made, you know, because the little Tsar had a lot of symptoms. So nothing in the female, full symptoms in the male. This is X-linked recessive inheritance. Interestingly, in the field of lysosomal storage disease, and we are with MPS España, so it may well be that some patients have MPS 2 or Hunter disease. It's a perfect example also. So boys are severely affected, while their mothers, for instance, have virtually no symptom. It's another example of X-linked inheritance. I've always been interested in this, since you can really consider this disease, MPS 2, like the cousin of Fabry disease. So why this difference? We will come back to it. Okay, we just saw X-linked recessive inheritance. So I guess you will agree with me that this statement published or written 20 years ago in one of the best, you know, textbooks of metabolic medicine, where the authors were writing that female with Fabry disease usually are asymptomatic, is no longer acceptable. Okay, I think nobody will agree with this statement tonight. So that was X-linked recessive inheritance. Let's now move to X-linked dominant disorders. What does it mean? It means that in those cases, the females are either equally severely affected as male patient, and sometimes the disease can be so severe that the males, they even die in utero, in the uterus of their mother, and we can observe only female patients with complete clinical phenotype, complete sign and symptoms. So should we consider with a group of Professor Beck in Germany, again, some 20 years ago, when they proposed that Fabry disease should be considered as an X-linked dominant disease, I personally disagree with that proposal or statement. I hope you will also follow myself. And so again, I would propose with Professor Dobbins that the truth is very probably in between, you know, and this is the reason why we propose to only say X-linked disease when it comes to Fabry, forget X-linked recessive, forget X-linked dominant. Why is that? Very clearly, female patients for Fabry disease, they are patients, you know, they do express signs and symptoms. Are the male patient, and I don't know exactly what is his color, kind of dark green, you know, or brown, are the female patients. And you can see on this work, I've been a co-author, that actually females here, they are affected in most organ, you know. So we have renal involvement, gastrointestinal involvement, cardiovascular involvement, ophthalmological involvement. We are talking Fabry disease, of course. And you can see that they usually start and enter the disease a little bit after the male patient. Another interesting slide is this one, where you can clearly see that among the community of Fabry females, you know, we can document difference in the progression of the disease. So look at the two red lines. You can here see a small subset, a small percentage of Fabry female for whom the progression of the renal involvement is high and rapid, you know. So those female, they will progress to end-stage renal disease. But you can see we are talking a very small number of females in that case. In the same time, we can here see another group of females, and actually much more numerous, here 51 individuals in that case, for whom the deterioration of kidney function is actually minimal. You know, they only lose 1 milliliter per year of glomerular filtration rate. So the kidney function only deteriorates by -1 milliliter. We are starting with 100. We reach dialysis only when we reach 10. So those females actually are not really at risk for renal disease. So this clinical observation, they also translate in biological information. And probably most of you have learned that using the enzymatic assay, so in other words, assaying the levels of alpha-galactosidase in the blood of potential Fabry females is not a good way to confirm the clinical diagnosis. It's not a reliable test. Why? If you look on that slide, on the left-hand side, you have the control population, so people without Fabry disease, okay? On the right-hand side, you have what we call, we geneticists, hemizygotes. It's our word for male patients, okay? Because they only have one X chromosome. You can see that alpha-galactivity is very, very low. But look, here in the middle are the values obtained for the female patients or heterozygotes. So if some of them have indeed relatively low values, usually not to the same level as male patient, here we can suspect. But you can see that here we have a percentage or a subset of true Fabry females, okay? They are heterozygote, they have Fabry disease, and you can see the alpha-gal overlaps levels, they overlap with the values that can be found in normal controls. So, as you can see on this slide, the situation for female patients is much more complex than what we can usually document for male patients. Why is that? As I told you at the beginning of my talk, the GLA gene responsible for Fabry disease is located on the long arm of the X chromosome. So Fabry females, they have two GLA gene, one here, the other one here. Okay, the male patients have only one gene located here. Of course, so if the gene is mutated or destroyed, there is nothing to compensate in the male patient because they only have the little Y chromosome. Okay. So at that stage, I would like to have some kind of a little bit philosophical, thoughts, because if you consider this situation for any medical geneticist, this is very surprising. You can see that any females on that planet Earth, okay, they have two X chromosomes. So any female has two X chromosomes, and while the males, any male on planet Earth has only one X chromosome plus this little Y chromosome. So this is unfair, Females have 2 times more genes than males. And for medical geneticists, this is very surprising because if, for instance, you consider just for a moment young children with trisomy 21, what is the situation? They have 3 chromosome 21 instead of 2 chromosome 21. And I guess that most of you also know that the clinical picture of those young children is not very nice. They may have intellectual deficiency and a number of malformation. So in human beings, missing genes, such as, for instance, patients who Fabry disease who miss a gene, they miss the GLA gene, is not good, but having too many genes is equally not good. So in that case, female patients who have twice as many genes of males than males should have problems if we consider that male is a reference, or if we consider, of course, that females are the reference, then the males who have only 1/2 of the X chromosome genes should have many clinical problems. This doesn't happen because nature, Mother Nature, has developed a mechanism to equalize the number of genes on the X chromosome. Well, that's not very important. So that point was suspected for the very first time, now 70 years ago, you know, using neurons of cats. But much more practically, it was really rediscovered and really explained by the way, a lady, you know, a British female geneticist, Dr. Mary Lyon, and this mechanism is named after her as lionization. What does it tell us? This X chromosome inactivation process, or lionization, explain us that in the embryo, so we are talking here a very little embryo in the uterus of the mother, which has just been conceived about 7-10 days earlier. Okay, so it's very, very early stage. So in every cell of a female embryo, one of the 2 X chromosomes that she will have received either from her father, 1 X chromosome, or from her mother, another X chromosome, will be inactivated, so will be silenced forever, for the whole life, okay? So look, on that picture, for instance, the maternal chromosome here in pink stays alive, stay active, and the paternal, the blue one, goes silent, okay? Here is a different picture, the opposite, okay? And here is the same picture as the first slide, the first cell, okay? And this usually occurs at random, so completely by chance. And once a cell has decided that, for instance, the paternal X is inactivated, it will be true for every daughter cells of this cell, okay? So for instance, if this cell is dedicated or supposed to give, let's say, the kidney, all the daughter cells will behave exactly in the same way. So let's look at the next slide. Very interesting example. On the left-hand side is not Fabry disease. This is Duchenne muscular dystrophy, a terrible, very devastating myopathy. Maybe you have watched on TV already. So here on the top is a normal control, okay? So you can see that around the muscular fibers, we can see this white, you know, halo, which is normal. Here, a male patient with Duchenne muscular dystrophy, no staining, so he's really very severely affected. He has no dystrophy. And here at the bottom slide, for instance, his mother, you know, and we can clearly see that some muscular fibers are completely normal here with my arrow, and in the middle, some fibers are completely devoid of dystrophin, exactly like male patient. This is the same here for Fabry disease. This is a kidney biopsy. Here, a male patient, everything that is brown is abnormal. We are talking a male patient. So you can see a lot of GB3 accumulation in the kidney. Here, a female patient. So some bad areas here is not very good. Here is not very good, okay, same here. But some very nice area where you have minimal involvement, okay? So you female patients, for those of you who are with us tonight, you are a mosaic a mosaic like in Pompeii. This is why I put that mosaic on my first slide, a mixture of good and bad cells, okay, depending on which X chromosome has been inactivated or silenced. This is what happens because, of course, this X chromosome inactivation is not only for Fabry females, this is for any kind of females on the planet Earth, okay? So you 50% of the paternal X chromosome, 50% of the maternal. This is a vast majority of female, but this is not always true, okay? And some females will, for instance, always inactivate the paternal X and keep the maternal chromosome. Here in the opposite, inactivation mostly of the X maternal chromosome, and they keep active only the paternal. If you have no genetic disease, no X-linked genetic disease, who cares? You know, nobody cares, and nobody even noticed this situation. But of course, if you have an X-linked disease, such as Fabry disease, if you are here, you will be in very, how can I say, complicated or difficult or bad category, okay, mimicking what can be seen in the male patient. In contrast here, if you are a female behaving like this, also you are carrier for Fabry disease, basically you will have nothing, okay? So that was my theoretical and intellectual hypothesis when I started this work, this experimental work, and we have, I think, very nicely confirmed and documented it in my laboratory. And last year it was, by the way, definitely confirmed by a Japanese group using a slightly different method. Okay, so what we did is we took 56 female patients with Fabry disease. For each of them, we studied those global severity score I mentioned before, but we also measured the kidney function, MGFR, and we measured the cardiac geometry. We assayed the alpha-galactosidase activity in the blood of the female patient, and we determined the X chromosome inactivation status using 4 different tissues, and we duplicated all the experiments. Here are the results. Out of 56 female patients, we got information for 55 of them. As I mentioned before, the vast majority of the female patients, they behave in inactivating roughly 50% of the paternal X chromosome or on the maternal. But look, in 16 cases, so first let's start with 7 cases, they had what we call skewed X chromosome inactivation. So they actually inactivated preferentially the bad chromosome, okay, the X chromosome bearing the Fabry mutation, okay? So that was a very good news for those 7. In contrast, those 9 female patients inactivated, let's say, the good chromosome, okay, leaving alive only the mutant one. So let's now have a look at the consequence of those 3 situations, those 3 groups, okay? So first, let's start with the measurement of alpha-galactosidase activity in the blood of those female patients. You know, we keep on bashing, you know, or criticizing the value of plasma alpha-galactosidase enzyme, and I was doing the same a few slides. The results of this X chromosome study. Here in orange, you have the group, the majority group, you know, the 39 patients who have inactivated 50-50. Interestingly, they have indeed 50% remaining alpha-galactosidase activity. It's very logical. It's encoded by the group, the good X chromosome, which is present at 50%, okay? If we consider the small group of 7 patients who have retained alive or active or lively the good X chromosome, you can see that those, they have actually 100% residual alpha-gal activity, mimicking very much normal controls. And in contrast, we were able to document a dramatically decreased, if not absent, alpha-galactosidase activity in the small subset of female patients who have inactivated the X chromosome in the wrong direction. Okay, that was alpha-galactosidase activity. We now move to the severity score, okay? Look here in blue. So in the middle in blue, we have the global severity score, whatever MSSI here and there, or DS3. You know that Fabry disease is a storage disorder. We are used to talk about lysosomal storage disease, okay? So we have storage, we have accumulation of undegraded GB3, and of course, the elder the patient, the more accumulation we have. So this is quite logical that the score increases with age, as you can see. But look here, the bad subgroup, you know, those ladies who have inactivated the good chromosome and left alive the bad one. You can see that the scores are always higher and the slope is also steeper. And in contrast here, in green, we have the subset of female patients who have inactivated their bad X chromosome, if I can say so. So that seems to be true for alpha-gal measurement. This is true for global severity score. This slide, I will go very quickly on it, but depending, it's another way to look at the results. If you fall in the good group, you know, those 7 patients, very low severity score. If you fall in the middle group, intermediate severity score. If you fall in the bad group, higher severity score. It's also true for angiokeratoma on the skin. And I would like to end up with maybe the 2 most important slides of my talk. So I first start with the cardiac results. So here we looked at left ventricular mass, so the cardiac hypertrophy. Yeah. So you can see that I will finish in 3 slides. So you can see that we have here an increase, you know, of the cardiac mass in blue in the middle group. Okay, so again, progression of the cardiac symptoms with age. But look at the much higher left ventricular mass in the 9 female patients who have inactivated the good chromosome. They have a much more severe hypertrophic cardiomyopathy. And here in green, you know, those females who have inactivated, again, the bad guy and kept alive the good X chromosome, virtually no cardiac disease. Next and final slide. This is now the kidney involvement. We don't want the value to go down. And you can see that here in blue, the main group, the values are going down, but actually they never reach the stage where the female patient will need dialysis, okay? Here also in green, it's very good, almost no kidney failure, no deterioration, and only the female in the bad group, you know, who have inactivated the wild type X chromosome, they can progress to end-stage Fabry disease. So in summary, on this last slide, depending on the X chromosome inactivation profile of any Fabry female, we are able to use this prognostic, you know, test to distinguish between 3 categories of female patients. Those for whom we should save the money of the healthcare system because they will not develop any major symptoms of Fabry disease. Those who should never be discriminated and should actually be considered as male patients from the point of view of Fabry disease, you know. And in response to a previous question, we would even now start young female patients, young girls, okay, and those in the middle where we discuss with our female patients, we take the advice, we carefully monitor them, and initiation and monitoring of therapy will depend on a partnership between female patient and doctors. So I hope I have convinced all of you about the importance of this process, and I would like to thank all of you for your attention. Thank you very much. I cannot hear you, Guillem. Maybe your microphone, Guillem?
Thank you very much, Dominique, for this very nice, very comprehensive presentation. We will have the questions at the end after the presentation of Professor Derralynn Hughes. Professor Derralynn Hughes, thank you for being with us today. Professor is professor in experimental hematology at the University College of London and clinical director of research and innovation at the Royal Free London NHS Foundation Trust. She is also chair of the European Working Group on Gaucher disease, and she directs the research program in the lysosomal storage disorders unit, where interests include understanding of the pathophysiology of phenotypic heterogeneity in Fabry disease, and also bone-related pathology in Gaucher disease and malignancy. Professor Hughes is a principal investigator of a number of clinical trials examining the efficacy of enzyme chaperone and gene therapies and other new agents in the treatment of Gaucher, Fabry, Pompe, and MPS disorders. Today, she is here with us and we ask her to present about the clinical trials and future therapies in Fabry disease. Thank you, Derralynn, and you can go ahead. Thank you.
Thank you so much, Guillem. Thank you for inviting me to talk this evening, and for the audience tonight for joining. So this is a really great time to be talking about future therapies for Fabry disease. I've worked in this area now for well over 20 years, and there is more going on than ever before. So these are my disclosures. So our specific intention when treating Fabry disease is to essentially find a way of reducing the substrate. And we can do that by replacing enzyme activity, or in fact by blocking its accumulation, by correcting the defects, reversing the storage, and then reversing the downstream changes that occur to the cells. And we do that in the hope and belief that it will improve the function of the cells and the patient, improve quality of life, and improve life expectancy. And so by starting at the beginning of that with enzyme replacement, or as it goes on now with substrate reduction therapy, our endpoints are those things that we see in terms of function, quality of life, and life expectancy. There are a number of different ways that we can treat Fabry disease using that approach. These are some of the possible therapies that have been used for storage disorders in general. Up until recently, stem cell transplantation was not something that we really thought about in terms of Fabry disease, but now in the context of ex vivo gene therapy, it has become very relevant. Enzyme replacement therapy, of course, has been our gold standard for 20 years. Substrate reduction therapy, which I will explain, is going into development now. And we've had chaperone therapy for approximately 5 years across Europe. We now have several studies on gene therapy, so a very exciting time. However, I think the most important message is that which Guillem gave in his talk earlier, which is that in fact, regardless of our treatments, unless we treat Fabry patients early, then we will be unable to avoid the long-term complications. So we could treat with early preventative intent, which might avoid those complications, but it would mean that we treat some patients unnecessarily. And that relates to Dominique's talk. Some patients, particularly females, may never go on to have any specific Fabry-related problems. It might also mean that we risk treatment-related complications. There'd be a cost of therapy and an effect on quality of life. On the other hand, if we only treat when manifestations become evident, then we risk having irreversible complications. So we reduce treatment-related complications, but exchange that for disease-related complications, and our costs become the management of morbidity, and equally we have an effect on quality of life. And I think this is really important as we design new therapies, because if we want them to be given early, they need to be of low treatment burden for patients. And if we're going to give them late, they need to be able to reverse the long-term manifestations. And that might mean that they're not only directed at reducing substrate. We've recently worked on a Delphi procedure with physicians across Europe and the rest of the world, trying to understand what some of those early indicators might be. And this is obviously quite a detailed slide, but it just shows that procedure of thinking around what the possible early treatment starting points might be. And then we work through them in various rounds of Delphi, coming up with these indicators of consensus. So not only hard endpoints for starting of left ventricular hypertrophy, but thinking about, for example, could we start early when there are very subtle changes in cardiac architecture or a very small change in microalbuminuria on a renal biopsy. And I think it's important as we design clinical studies to take this into consideration. What are the earliest time points, and would that lead to a benefit for treating our patients? I've highlighted the milestones in therapy, and it really is quite dramatic over the last 5 years in terms of the proliferation of new possible treatments. And I'm going to try to step through some of those during this talk. In order to understand how to build new treatments for Fabry disease, we need obviously a better understanding of the condition altogether. That means an awareness about the condition, an ability to make the diagnosis. Now, that of course seems self-evident. We need to be able to measure enzyme activity and to genotype the patients. But it's only over the last few years that we've realized that that must also be correlated with clinical features and with substrate within the plasma, urine, and within the tissues. Otherwise, we have the possibility of making the diagnosis of variants of unknown significance of patients who have changes within the alpha-galactosidase A gene, but which don't necessarily correlate with any pathology. And that's also particularly important for clinical trials. If we go back and look at the trials that have been performed in Fabry disease over the last 20 years, there are a number of examples of patients who've been included who we might at this point say, well, maybe they didn't actually have a full classical or a full late onset manifestations of Fabry disease. Oops. So we need to understand the phenotype and how that relates to the genotype and underline the pathophysiology. And without that understanding, it's very difficult to perform an appropriate novel intervention. With those, we will get to the point where we have better therapies But again, we'll only be able to understand how well they perform in clinical trials if we have an appropriate outcome measures. This is a hierarchy of clinical trial outcomes, and all of these have been used in Fabry disease. So we have pharmacokinetic and pharmacodynamic measures, as with all clinical trial programs, understanding how the enzyme moves around the circulation and how it impacts on substrate. Then how it impacts on biomarkers. We have to think about both biomarkers of the biology of the disease, as well as those which tell us about substrate. We have surrogates of treatment effects, such as left ventricular hypertrophy, such as change in GFR. They're not actually outcome or endpoints, but they are surrogates which are related to them. And then we have those features which are important both to the patient and to the regulators. So how does a patient feel? How do they function? And how do they survive? Now, unfortunately, the ease of measurement is inversely proportional to the importance to patients as outcomes. It's very easy to measure pharmacodynamics and pharmacokinetics, and much more difficult, takes much longer to measure functioning and survival. And that leads us to a problem in clinical trial design. So again, in another Delphi procedure, this time led by David Moreno-Martinez, who's a student colleague of Guillem, who he's very kindly sent to do a PhD with us in London. So David led this Delphi over a couple of years in total, looking at the opinions of physicians over the whole world, in fact, all the continents. And we looked at what possible outcome measures might be so that we could have some standardization and try to move closer to those elements of feeling, functioning and survival. We had lots of outcome measures met, consensus here, but it starts to give us some kind of a structure that we could use for assessing how well studies perform. So for example, could we evaluate overall cardiac improvement by looking at a cardiopulmonary function test or an exercise test or a tolerance questionnaire, or in fact, real world digital data on how much people are moving, rather than just looking at a 6-minute walk test, which is a little bit of an isolated measurement. You can see here some of those other important features for clinical trials that we looked at, including what sort of patient should we include in a clinical trial. Our overall consensus here was that we would want to ideally perform a relatively long trial, up to 5 years, with some kind of adaptive methodology. So the sort of methodology where we can make comparisons but adjust those over the time of the trial so that we start to understand what are the most important results as we go forward. We thought that in all likelihood, it would be best really to start with symptomatic and probably classical male patients so that we had the best opportunity of understanding the impact of the new therapy. But then that adaptive design would allow us to go on to include later onset and female patients. And we felt that important exclusion criteria would be those variants of unknown significance. And of course, some of the end stage outcomes, which might be irreversible and might make clinical trial participation or measurement difficult, such as stroke or renal transplantation. So why do we need better therapies for Fabry disease? We've had enzyme for 20 years and many of our patients have benefited hugely from having enzyme replacement. However, after having 20 years of bi-weekly infusions, many of them are looking for greater convenience, for something which is less frequent or is less burdensome in terms of those infusions. We're also looking for something which actually addresses potentially those other cellular manifestations of the disease, or which prevents the end-stage irreversible manifestations such as fibrosis. And that leads us to think to some of the other limitations of enzyme replacement. So how well does it get into the tissues? How well does it circulate around the body? We know that enzyme is actually removed from the circulation pretty quickly, over 24, 48 hours. So is it possible to design something which stays in the circulation for longer? And then we also have the potential limitation of antibody formation. And despite knowing about antibodies since the original clinical trials in 1999 or so, it's only very recently through the work of multi-lenders and others that we've come to appreciate the impacts that neutralizing antibodies have potentially on outcomes, not only reactions, but also reducing the changes that we see in the heart and so on in Fabry disease. So addressing convenience, addressing effect, and addressing immunogenicity. Small molecule approaches to Fabry disease, therefore, are very appealing because they have the advantage of usually being orally bioavailable, of not being immunogenic because of the nature of the drugs, and potentially having the ability to cross into the brain, and so maybe starting to address some of those features which, thus far at least, we don't have good evidence from enzyme replacement therapy. There are challenges, of course, in terms of toxicity of new products and establishing dose. We know from work that we performed in the UK that the population on the whole would prefer to have an oral treatment. This was some work that we performed in preparation for marketing approval and commissioning payment of migalastat. And we asked the general population if they would prefer to have an oral treatment, which some of the side effects that we knew may occur with oral treatments, such as headache, or an intravenous treatment with a possibility of an infusion reaction. Now, overall, as you might expect, that population valued having a good treatment which increased life expectancy. That was their overall consideration. But that being equal, they elected they would prefer to have an oral treatment with headaches potentially than an intravenous treatment with infusion reactions. So that gives us some support for the concept of oral therapies. And of course, we now have available to us pharmacological chaperone therapy, which works through binding of the mutant enzyme and the ability, therefore, to allow it to form a better configuration and move through into the lysosome. Now that's, I think, is a treatment that's well established. I'm not going to go through any more now into the developmental program, but I show that really to illustrate now the difference with the new oral therapy, which is under clinical trial. And that's substrate reduction therapy. Those of you who work in Gaucher disease will be familiar with both miglustat and deliglustat, which are two oral substrate reduction therapies which have been used to good effect over the years in Gaucher disease. The concept is that rather than breaking down the accumulated storage material, its production is inhibited by blocking the early components of the synthetic pathway. So the SRT, or substrate reduction therapy, blocks the addition of glucose onto ceramide by blocking glucosyl ceramide synthetase and thereby prevents the buildup of lactosyl ceramide, globotriaosylceramide, ceramide, and other products within that pathway. It leads to the potential that those oral treatments might be available for other conditions, not only Gaucher, but also Fabry or others such as Tay-Sachs or GM1, for example. In Fabry, there are two treatments which are currently, or two investigational products which are currently under evaluation. Excuse me. One of them is venglustat, and this has been gone through a phase 2 study. You may have seen some of the data from that presented at LDM over the last couple of years. And of interest, venglustat is also, that moved without me doing anything. Of interest, venglustat is also under study in a number of other conditions, in neuronopathic Gaucher disease, in Parkinson's disease and also in polycystic kidney disease. And I think the relationship there between polycystic kidneys in Fabry and genetic polycystic kidney disease and the use of venglustat is quite tantalizing. The other treatment, which is currently under study in a phase 3 trial called the MODIFY study, is lucerastat. So this is just a cartoon showing how substrate reduction therapy works. So instead of having an equipoise between the production of substrate of GB3 and its reduction, in Fabry disease, we have increased production. Enzyme would break it down, whereas oral lucerastat or venglustat prevents its buildup. This is the design of the lucerastat study, which is, I think, due to report in the next 6 months or so. So patients on an oral treatment with outcome measures relating to, interestingly, to pain and gastrointestinal symptoms. This is venglustat, which has basically completed the phase 2. Okay. So when we were thinking about which treatments, what were the benefits of new treatments, we thought about, or I mentioned, pharmacokinetics. So is it possible to have an enzyme within the circulation for longer so that we reap the benefits of having exposure to enzyme for the full 2 weeks, or even longer than that? Is it possible to have it over 4 weeks, perhaps, so that patients don't have to be infused as frequently? There is a study of PEG uniglycidase alpha ongoing at the moment. This is a chemically modified alpha-galactosidase A, where the homodimers are linked together with a polyethylene glycol residue. And this extends the stability within the plasma, increasing the half-life. This is some results from the phase 2 study, which has both been presented at LDN and also now published, which shows in the top panel how that half-life is increased. And in fact, the PEG uniglycidase alpha becomes available within the circulation for the full 2 weeks. And this was consistent both for 0.2 milligrams, 1 milligram, and 2 milligrams per kilo. In fact, to the extent where the 2 milligram per kilo accumulated if it was given every 2 weeks. So that led to the possibility that it might be possible to give a 4-weekly dosing of 2 milligrams per kilo. In the phase 2 study, we saw that both at 0.2 mg per kilo and 1 mg per kilo, there was reduction in the peritubular capillary GB3. And there was also stability or reduction in the change in the LVMI. These patients were relatively well. We didn't see many patients with significant LVH at baseline, but there were some changes notable in the right direction here. Interestingly, in the phase 2 study, we only saw 3 patients generate anti-drug antibodies. And those patients both self-tolerized during the course of the study, suggesting that that longer half-life and availability within the plasma actually led to ultimately to a self-tolerization, so potentially also addressing the immunogenicity. And as the immunogenicity was overcome, we saw the restoration of the circulating antibody. So when the antibodies were present, the enzyme's half-life was reduced, but as the antibodies disappeared from the circulation, the half-life once again extended. So there are now 3 phase 3 studies, one which is in comparison with Fabrazyme, one which is a switch from Replagal, and then one which is looking at 4-weekly studies, and again, all due to report over the next year or so. So finally, I'd just like to address gene therapy for Fabry disease. So this, of course, has been long awaited, but is now a reality. There are several studies currently looking at both in vivo and ex vivo gene therapy for Fabry disease. In vivo is when a viral vector, usually an adenovirus, with the enzyme construct is given intravenously to the patient as a one-off infusion and goes to the liver to produce the enzyme to perform an enzyme factory. Ex vivo is when stem cells are harvested from the patient. The patient has some mild conditioning with chemotherapy. The stem cells are manipulated with a lentiviral vector containing the alpha-galactosidase, and then they're reinfused into the conditioned patient, where they travel to many organs in the body, and again, act as little factories for the enzyme. This is some cartoons just showing what the in vivo gene therapy looks like. So in this case, we don't need stem cell harvest or any real manipulation of the cells themselves. So you can see that the patient is infused and then the enzyme produced. And this is some data presented by Freeline at LDN, showing the hepatic expression of the GLA gene, resulting in availability of plasma alpha-galactosidase A, which is subsequently taken up by various organs in the body, reducing reduction of GB3. This is in a mouse model, and we dosed our first patient at the Royal Free with in vivo gene therapy. Now, probably nearly 2 years ago. Unfortunately, we had a bit of a hiatus due to COVID, understandably, but now everybody's getting going again with the various research programs. There are potential risks with in vivo gene therapy. We might develop an antibody to AAV, making subsequent infusions not possible, or an antibody potentially to the alpha-galactosidase A enzyme. There's a risk of hepatitis, and we need to think carefully around managing that, but it is very possible to manage it. It's a short-term effect. And of course, there's theoretical risks of insertional mutagenesis and so on. For ex vivo gene therapy, as I've said, there is a stem cell harvest and introduction in the lentiviral vector. And again, results of ex vivo gene therapy have presented by the team based in Canada, who've dosed a number of patients. And this is now a trial that has been run by AvroBio, mainly in North America, I believe. Potential risks of ex vivo gene therapy are generally around similar in terms of creating antibodies, but also really around the chemotherapy, immunosuppression, and so on. So I think there's some interesting questions as we go forward with gene therapy, and our patients will want to know how we should address this. So which should we be using, ex vivo or in vivo? I think we don't know the answer to that. Is it useful to have a liver-specific vector or a other tissue or a multi-pluripotent vector? What dose and what immunomodulation? Can we repeat the treatment, or is it one-off? And then which sort of patients might benefit most? If we compare gene therapy with the other treatments that are currently available or under evaluation, you see that one of the biggest questions around this is what the commissioning model would be. What is the cost? How do we work through that? And that's something that we'll need to think about in the future. All our treatments have various risks and benefits, and the most important issue at the moment is to understand what they are so we can inform our patients appropriately. So this, I think, comes down to some extent to the benefits of a pharmacokinetic profile. You can see here the sawtooth effect of enzyme being in the circulation every 2 weeks. And then with pharmacological chaperone therapy, we maintain a slightly increased level of enzyme at a consistent way over the whole period. We have potential with enzyme replacements which are pegylated to stay within the circulation for longer, thereby also increasing the area under the curve and exposure of the enzyme. And then potentially the increased elevation, increased level of enzyme with gene therapy, which may be more sustainable within the circulation, all to be answered during these clinical trials. There are some challenges for us which we don't yet understand. So What, for example, is the relative importance of that peak concentration in forcing the enzyme into tissues compared to a greater total area under the curve? Does it matter whether the enzyme is in the plasma or whether we have tissue-specific expression? And what is the relative clearance of substrate within the plasma versus substrate in the tissues telling us? And then finally, how closely do those biomarkers and surrogates actually predict important outcomes for patients? So in conclusion, I think there are really important results for enzyme over the last 20 years. We've definitely seen benefits of early therapy, and that's something that we need to consider. But now we have a rich armamentarium potentially of new enzyme therapies, new oral pharmacological chaperone and substrate reduction therapies in investigation. And then now this whole emerging technology of new gene therapies. So thank you so much for the invitation, and I hope there's still some time for some questions.
Thank you. Thank you very much. Derralynn, was a fantastic presentation. I have now one question here for Professor Germain and some for Derralynn. So we start with Professor Germain. Apparently, this type of X inactivation is a mechanism that will be present in all the X-linked diseases. So why many of the X-linked diseases, the females are only just without any symptomatology, and in Fabry disease there is so many female with symptoms. Where is the problem? What is the difference even in lysosomal disorders like Hunter or Fabry, where you don't have hardly any symptoms in a female Hunter. However, 75% of the females with Fabry have symptomatology. So what is the difference?
Thank you for those questions. There are at least 3 questions in one, actually. I will be able to answer only partly. So first, it's not correct to say that it doesn't exist in other diseases. If we first consider Duchenne muscular dystrophy, the same process is quite important. You know, we did a small pilot study because we do not have as many female Duchenne female patients, but the same is true. So when we were able to demonstrate skewed X inactivation in the wrong or bad direction, the Duchenne female, they do express a much more severe cardiomyopathy. Okay, so that's one. Coming back to Hunter, the difference between Hunter and Fabry, it seems, and it was relatively nicely demonstrated by some work of Maria Fuller, an Australian scientist, that the key difference is that there is a kind of cross-correction in the Hunter cells. So it means the good or healthy cells are able to secrete enough enzyme which is recaptured by the disease cells. You know, for whatever reason, this doesn't seem to occur in Fabry females cells. And so in an attempt to merge, you know, or synthesize or summarize those various first element of answers, one model has been proposed which differentiates between X-linked disease where cells can be considered as autonomous, or when there is influence, you know, and kind of interaction of cross-correction between one cell and its neighbor cell. And so currently, this is, how can I say, strongest explanation explaining the difference that you have just mentioned, Guillem. Okay, so if I want to also briefly rephrase for Fabry disease, so altogether, one, inability to cross-correct, okay? So that tells us that unfortunately the healthy cells doesn't seem to be able to rescue the neighbor sick cells, okay? So that's first part of the picture. And then of course, within the cells themselves, depending on the profile of X chromosome inactivation, you will have more or less healthy cells, okay? And you saw that for the sake of time, I skipped the 3 or 4 last slides. They were actually related to later onset Fabry disease, where it's very, how can I say, obvious or easy to understand that this X chromosome inactivation profile is maybe not exactly of the same value. It's more important for classic Fabry disease. Why is that? In the worst case scenario of later onset Fabry disease, even the diseased or sick cells, they still have, let's say, 25% of or 20% of residual enzyme activity. And again, this is the worst case scenario, okay? And of course, the healthy cells have 100%. So when you make the mixture, you're well above experience, at least. I don't know if Derralynn would confirm, but these of the 4 subsets of potential Fabry patient, I mean, classic male, classic female, late onset male, late onset female. Later onset females are by far the mildest category.
And another question also for you, Dominique, is from Mercedes Navarro. She says, the loss of the X chromosome due to the age, could it affect the Fabry phenotype?
So there are some Canadian seminal work on this, which tell us that in the tissue, it doesn't seem to have any variation according to age. But in the blood, this is a work of Dr. Bousquet, it was shown that probably depending on some, selective advantage that may finally have the healthy cells, in quickly dividing cell types, such as, for instance, the hematological cells. Progressing with age, we usually observe a skewing in favor of the wild type allele. So in the good sense, okay? We were able to document this in our work, but however, it didn't reach statistical significance, and it didn't seem very clinically important to me. So to recap, in the tissue, no major changes. It's fixed, from birth, I would say. We now use, by the way, we use it as a predictive testing in young children, in young girls. And in the blood seems to move into the good direction, but without, real clinical benefit. But maybe our study was lacking statistical power.
Okay, thank you. Thank you. Thank you very much for these very nice answers. Derralynn, we have one question that is for you, and that was done before, is there is always, do you think that the oral treatments have to be or may be used together with ERT, or is a separate type of, always a separate type of treatment?
Thanks. So that's a really interesting question. I think there is a logic to potentially using the oral treatments with enzyme because they affect different parts of the pathway. But that's with the caveat that you would need to have some kind of data to support that, because there's always a potential for an unexpected interaction between two drugs. And so whilst substrate reduction therapy and enzyme may well be a good combination, we'd want to see some data on that, and similarly, potentially also chaperone therapy. In Gaucher disease, I have some patients who have, because of very severe disease, are on both treatments with compassionately. One of them is being given in compassionate grounds. So I think we should get the data, and then there's also a question of looking at the dosing of the oral. It may not be necessary to give the oral in the same dose. And then also, what is the funding for having both?
So you think that theoretically there may be some kind of synergies between these different types? Okay.
Yeah, potentially.
Another interesting question here from the public is why apparently all these pharmacological studies don't have into account the people with advanced renal or cardiac affectation that are for treatment, long-term treatment, and apparently without a good response to the treatment.
Yes. So of course, it's really important to address the long-term outcomes in patients who already have significant renal or cardiac disease. And there are different reasons why we might not want to do those in the same study. So if we consider renal disease, it may be that the oral drugs are renally excreted. And so if you are to do a study in a renal patient with lower renal function, then you may need to give a different dose and monitor the pharmacokinetics for the effect. So that's one reason. The other reason for both cardiac and renal patients who already have end-stage changes, it's very unlikely that there would be a reversible change by altering the substrate. And so you're stacking the changes, the odds against us in a clinical trial. And I think in those particular areas, it's really important to think of other strategies. So is there a strategy to reduce fibrosis or reduce inflammation to try to get on top of the changes in those diseases rather than just reducing substrate?
Okay. And there is also another one is by Godoy Rosa Analia. And I think she is referring to the genetic studies. She says, she asked, do these methods can be used in children with Fabry disease?
So there would need to be a clinical trial in children, of course. So at the moment, we're looking in adults. However, there are a number of gene therapies which, for other conditions, which are being looked at in children with severe genetic diseases. And so there's no reason eventually why they shouldn't be used in children. And that may turn out to be the most appropriate time, as long as we can predict which are the children who would benefit most in the future.
Okay.
I don't know if I can. Just if I may comment, can you hear me? Yeah. For I think Derralynn will confirm to consider hepatotropic AAV gene therapy in very young children. We have to consider the fact that the liver cells will divide a lot, and so the therapeutic effect may be kind of diluted or lost with hepatic cells division, so that a number of pediatricians will tell you that below the age of 10, it's not currently the primary, the first line gene therapy that would be considered. But of course, that may well change with research progress in a close future.
Yeah, no, I think that's absolutely right. And I think the other thing we'll see with the gene therapy over the next few years is that we'll probably start to use more organ-specific vectors. So people will get more canny with the vector or with the promoters, so that if we have a mainly cardiological disease, we'll start to see a cardiological effect. But I mean, that's still to come.
Okay, so yes, you.
Yeah, my question to you, Derralynn, is what is your opinion about integrative gene therapy? You know, I'm a medical geneticist, so always concerned manipulating the genome. So what about integrative gene therapy using a lentivirus at a time where less invasive, therapeutic options are potentially including, for instance, mRNA, which have been really developed with the coronavirus pandemic. So what is your opinion about still using an integrative approach susceptible to trigger oncogenesis when less invasive therapeutic options are more and more emerging? Do we still have room for this?
So I think it's a good ethical question, and it's all around the potential risk and benefit and convenience for the patient's being appropriately informed. I think with good design, the risks are much more limited than they might have been 20 years ago when we saw some of those oncological effects in children. But you make a good point. If patients are willing to have ongoing, very safe enzyme replacement therapy, then what do we need to do in the design of gene therapy to make it safe enough for it to be an advantage for them? I think if we fast forward 20 or 30 years, then gene therapy will be our standard of care, but I'm sure that it will have developed significantly from our early start now.
Thank you.
Okay. Thank you very much to both of you. It was a very, very nice discussion, but I think that we have to stop here. And I think that was really a very good season conference in terms of showing the different aspects of Fabry disease in terms of treatment and female heterogeneity and also cardiac manifestations. Tomorrow we will have another day with Dr. Politei talking about the impact of COVID on Fabry and other lysosomal disease patients. And we also new aspects about the nutrition in Fabry disease, and different aspects of psychological aspects and sexology in Fabry patients. So for tomorrow, I expect that all the assistants will be also interested in to attend the Congress. And thank you very much to all of you, and have a very nice evening.